Imagine going in for, a seemingly routine elective procedure. You're sitting comfortably in the treatment chair, and you accidentally walk out with severe permanent organ damage.
Yeah, and all because of a piece of plastic implanted inside you a decade ago that neither you nor your new doctor remembered was there.
Exactly. And that is why today we're looking at why your past medical records are really the only thing preventing modern medical lasers from turning your pelvic floor into a microscopic minefield.
Right. We're dealing with an anatomical landscape where surgical precision is just everything, but deep tissue visibility is remarkably low.
Yeah.
If you've had any prior pelvic surgery and you're stepping into a clinic for something new, navigating that space without a highly detailed map is a massive clinical risk.
Which brings us to our core mission for today's deep dive. We want to equip you, specifically those of you listening who have had prior pelvic surgeries, with the exact knowledge of what medical records you actually need to bring to any future consultations.
Absolutely.
But more importantly, we're going to break down the physical mechanics of why those records are the ultimate safety net for your future care. To do this, we are pulling from a really heavy stack of clinical guidelines.
Oh, yeah, we've got a lot of sources today.
We really do. We're looking at protocols from the National Institute for Health and Care Excellence, or NICE, the Royal College of Obstetricians and Gynecologists.
That's the RCOG.
Right, the RCOG, as well as the British Society of Urogynecology, and some really rigorous surgical best practice reports.
And, these documents, they outline an incredibly complex environment. The goal here is to move away from viewing your medical history as just like a stack of bureaucratic paperwork.
Right, it's not just forms to fill out in the waiting room.
Exactly. You need to understand it as the essential biological blueprint that dictates how your body will react to any new medical intervention.
Okay, let's unpack this. If you are compiling your medical folder before heading to a consultation for a new pelvic symptom, or maybe exploring a modern energy-based treatment, what exactly needs to be in that folder?
Well, it's quite a lot.
Because we aren't just talking about a one-page summary from your general practitioner, are we?
Not at all. The clinical guidelines demand a comprehensive architectural and cellular baseline of your pelvic health. Rather than viewing this as just a random checklist, we have to group these records by their biological mechanisms.
Okay, that makes sense.
First, doctors need to establish your cellular baseline. This means bringing your most recent cervical screening dates, any colposcopy reports, HPV status, and recent infection panels.
Oh, because those records dictate the immediate microscopic environment the doctor is walking into.
Right.
Like, you can't safely introduce a medical laser or a scalpel into an area with undocumented viral activity or, cellular friability or an active bacterial inflammation.
Exactly. The tissue simply won't heal correctly. That underlying cellular health dictates the tissue integrity.
Wow. Okay, so what's next?
Moving beyond the cellular level, the second category is your structural history. This includes your complete birth history, focusing heavily on the mechanisms of delivery and any unhealed postpartum injuries.
Got it.
It also covers the exact insertion dates of any coils or IUDs.
Wait, really? Even just an IUD?
Oh, absolutely. The longer a device sits in the uterus, whether it's copper or hormonal, the more the surrounding local tissue architecture adapts to its presence. It alters local inflammatory responses.
I see how this builds a profile. So we have cellular and structural. What about symptoms and surgical notes?
Well, the structural baseline also requires rigorous documentation of any prolapse symptoms, whether that manifests as a physical bulge, pelvic pressure, or specific mechanical failures in bladder and bowel function.
Right.
And finally, the most vital layer is your deep surgical history. We need the operative notes from any previous prolapse repairs, synthetic mesh implants, or hysterectomies.
Okay, I'm going to push back here on behalf of the listener. Let's play devil's advocate for a second.
Sure.
If someone is just going in to ask about a routine surface-level elective procedure, maybe, like a vaginal laser treatment for a subjective feeling of laxity handing over a decade-old cervical screening, or a dusty hysterectomy report, feels like massive overkill.
It does sound like a lot.
Right. Why does a cosmetic or elective consult require a deep-dive surgical history?
Because in this specific area of the body, surface-level interventions inevitably interact with deep structural realities. Procedures utilizing energy devices cannot bypass proper anatomical screening simply because the treatment feels elective.
Okay.
We have to examine the clinical discrepancy between subjective laxity and objective pelvic organ prolapse.
Which are two very different things.
Completely different. Laxity is a subjective sensation of looseness, whereas prolapse is a measurable anatomical descent of the pelvic organs.
So a patient might feel subjective laxity and assume they just need a quick laser tightening procedure, but they're completely unaware of an underlying anatomical failure.
Exactly. So treating a subjective feeling with an energy device when there's an undocumented prolapse or an active infection present is a severe clinical hazard.
It basically masks the deeper structural deterioration and delays the necessary intervention.
Treating the symptom without mapping the underlying anatomy is clinical negligence. If there are red flags present like unexplained bleeding, undiagnosed descent, or active inflammation applying thermal energy can severely exacerbate the underlying pathology.
Which means handing over a piece of paper that simply says vaginal hysterectomy 2018 isn't the map. That's just the cover of the book.
Beautiful way to put it.
The doctor actually needs the nitty-gritty surgical notes to understand how the internal landscape has been physically and permanently altered.
Right, because virgin tissue behaves predictably. It absorbs energy evenly and heals along anticipated biological pathways, somewhat like a clean sponge.
Okay, a clean sponge. I like that visual.
But post-surgical tissue is entirely different. It's like a sponge full of dense, hard knots.
Oh, wow.
Prior pelvic surgeries fundamentally changed the tissue architecture. They introduce unpredictably dense scar tissue and shift vascular networks.
So it's not just the surface that changes.
Not at all. According to GRFT, that's getting it right first time, and the RCOG best practices, a proper surgical note for a vaginal hysterectomy has to detail the exact grade of prolapse at the time of surgery, the exact size of the uterus, and crucially, whether the internal anatomy was distorted prior to the first incision.
Basically, they are looking for the collateral damage or the structural compromises made during that original operation.
Exactly. They need to know what the previous surgeon had to maneuver around. They're hunting for invisible variables.
Like what?
Well, like, did the original surgeon encounter intraoperative complications? Was there accidental trauma to surrounding structures like the ureter? What was the estimated blood loss? Because that can indicate extensive vascular disruption.
That makes a lot of sense.
And perhaps most importantly for your long-term pelvic health, what specific materials were used to close the vaginal vault?
Okay, I want to stop on that materials aspect. Are you saying the specific brand or chemical makeup of the thread used to stitch someone up continues to matter years or even decades later?
It fundamentally dictates how the tissue remodels itself over the long term. We see this heavily emphasized in the archaic guidelines regarding OASIS.
And OASIS refers to third and fourth degree severe perineal tears during childbirth, right?
That's right. The operative notes for an OASIS repair must specify whether the internal or external anal sphincter was reconstructed and the exact sutures deployed.
The thread type is really that important.
Huge difference. There is a massive clinical difference in tissue outcome when a surgeon uses a braided suture like 3,0-polyglactin versus a monofilament like PDS.
Okay, let's break down the mechanics of that. Why does a doctor evaluating you for pelvic floor dysfunction 5 years later care about polyglactin versus PDS?
Because the chemical breakdown of those materials creates two entirely different healing environments.
Yeah.
Polyglactin absorbs relatively quickly. As it degrades, it creates a specific type of transient localized cellular inflammation. But PDS, conversely, is designed to retain its tensile strength and stay in the tissue for months.
So it provides prolonged mechanical support.
Yes, but it creates a denser, more permanent kind of microscopic scarring as the tissue slowly heals around it.
If we connect this to the bigger picture, a surgeon diagnosing a new onset of pelvic pain or altered sensation today needs to know the origins of the scar tissue they're feeling.
Precisely. They need to know if they are looking at a localized nerve entrapment caused by a long-lasting PDS suture, or if a previously repaired sphincter relying on quick-absorbing thread is now structurally failing under pressure.
Wow. So without the operative note detailing the suture material, the new surgeon cannot accurately diagnose the mechanism of your current pain.
They're basically just guessing at the structural integrity of your pelvic floor.
We just established that surgical history leaves behind unpredictable scar tissue that changes how the body handles pressure or absorbs new treatments.
Right.
But scar tissue, no matter how dense, is still natural human tissue. The danger multiplies exponentially when we introduce materials into the body that were never meant to be there permanently.
Absolutely.
Here's where it gets really interesting. We have to talk about vaginal mesh.
Yes. Synthetic mesh represents the ultimate hidden variable in pelvic medicine. From a material standpoint, we are generally discussing a permanent plastic implant manufactured from a non-absorbable polymer called polypropylene, which is often known as proline.
Okay.
The fundamental mechanism of this mesh isn't just to act as a passive hammock holding up descended organs. It is explicitly engineered for permanent tissue integration.
Meaning the body's own biological tissue physically grows through the microscopic pores in the plastic netting. It locks the plastic into the anatomical structure.
Exactly. The tissue mounts an inflammatory response involving macrophages and giant cells that eventually deposits collagen right through the pores of the mesh. It becomes an inseparable hybrid structure.
But that permanent, dense integration is the exact mechanism driving the severe complications meticulously documented by the FDA and the UK's Cumberledge report, titled, "First Do No Harm."
That's the tragic irony of it. Over time, as human tissue naturally remodels and shifts, the integrated plastic mesh can contract. It can cause erosion, where the abrasive plastic physically protrudes through the delicate mucosal lining of the vagina.
And the cascade of issues from that is just devastating.
Unbearable for many.
The chronic inflammatory response to this permanent foreign body leads to debilitating nerve pain, persistent antibiotic-resistant infections, and direct mechanical trauma to the bladder or bowel as the inflexible implant shifts against them.
Yeah, the sheer volume and severity of those mechanical complications forced a monumental systemic shift in clinical practice. Since July 2018, a strict restriction has been placed on the use of vaginal mesh for stress urinary incontinence and pelvic organ prolapse in England.
So for the vast majority of patients seeking treatment today, it simply should not be offered.
Right. But that restriction doesn't erase the past. Millions of individuals already have these permanent polypropylene implants integrated into their pelvic floors.
Which is why, if you are a listener with a prior mesh insertion, your surgical record is the most critical document in your possession.
It really is. Because if a patient experiences these late-stage complications and requires mesh removal, the surgical team is facing a highly volatile, complex inpatient procedure.
Because the human tissue has inextricably woven itself through the polypropylene. Complete removal is frequently impossible without catastrophic damage.
The surgeon constantly has to weigh the risk of leaving inflammatory plastic fragments behind against the grave risk of inadvertently excising a portion of the urinary tract or the bowel during the extraction.
That brings us to a terrifying collision of technologies.
Oh, this is the scariest part.
If you have this hidden integrated plastic mesh, or even dense, unpredictable scar tissue from an old repair, and you walk into a clinic for a modern vaginal laser procedure, your medical folder isn't just administrative paperwork. It is literally the targeting software the doctor requires to calibrate that laser safely.
Without that precise targeting software, a clinician is firing high-intensity energy blind into a highly volatile environment.
Like remodeling a house with power tools when you have no blueprint of the electrical wiring.
Perfect analogy. To grasp why this is so physically dangerous, we have to examine how different gynecological lasers interact with human tissue versus synthetic materials. Not all lasers produce the same thermal footprint.
Because a medical laser isn't just like a universal heat lamp.
No, not at all. They operate on highly specific wavelengths that target different cellular components.
But what are the differences?
What's fascinating here is the distinct physics of each device. Consider CO2 lasers. These operate on a wavelength that rapidly vaporizes intracellular water.
Okay, and since human tissue is mostly water...
Exactly. The energy is absorbed almost instantaneously upon contact. This gives CO2 lasers a remarkably shallow penetration depth, typically only about 0.1 millimeters into the mucosal surface.
Oh, wow, that is incredibly shallow.
Very shallow. Because their thermal footprint is so highly contained, they are generally considered safe to use even in close proximity to thin-walled critical structures like the bladder or the ureter.
It's essentially skimming and resurfacing the very top layer of the cellular architecture without sending shockwaves of heat down into the structural basement.
Right. But then contrast that shallow vaporization with an NDIAG laser.
Okay, what does that one do?
This device emits an invisible infrared beam engineered specifically for deep tissue coagulation. It doesn't stop at the water in the surface cells. It penetrates 3 to 4 millimeters down into the tissue beds.
That's a huge difference.
Massive. Alternatively, you have argon or KTP lasers, which emit green or blue-green light. These bypass water entirely and are rapidly selectively absorbed by hemoglobin in the blood or heavily pigmented tissues, which is why the operators have to wear protective goggles.
So if a doctor fires an NDYAG laser aiming for deep thermal coagulation to stimulate collagen production in the vaginal wall, and they do not have your surgical notes detailing a mesh implant sitting 3 millimeters deep.
The infrared beam completely bypasses the surface tissue and directly strikes the hidden synthetic polypropylene mesh.
Oh no.
And polypropylene is not designed to absorb or dissipate high-intensity laser energy like human tissue does. The laser rapidly superheats the plastic.
A melt.
It can cause severe thermal injury to the implant itself, potentially melting or warping it, while simultaneously transferring that intense trapped heat directly to the delicate bladder or bowel walls, resting immediately against the mesh.
That is horrifying. And the same catastrophic heat transfer could happen if that deep penetrating laser hits dense hidden scar tissue or altered vascular networks.
Yeah.
Right, because they absorb and scatter light energy completely differently than virgin tissue.
Exactly. Thermal scattering in scarred environments is highly unpredictable. This physical reality is exactly why the clinical guidelines mandate device-aware care.
Right.
The energy device itself is a valuable clinical tool, but applying deep penetrating physics to a patient with an undocumented, altered anatomical baseline is a recipe for severe internal burns and organ damage.
Let's look at the reality for you, the listener, navigating this system. Expecting a patient to perfectly curate their operative notes, memorize their exact suture degradation times, and act as a walking biological encyclopedia from clinic to clinic is a massive, often impossible burden.
It's too much to ask of one person.
Right. If someone had a prolapse repair a decade ago, they likely have no idea what specific chemical polymer was used for their mesh. How is the medical infrastructure actually adapting to track these invisible variables so the burden doesn't solely rest on the patient?
Well, the systemic burden is shifting. In light of the complications we've discussed, the NICE guidelines have mandated a robust systemic safety net. They have aggressively pushed for the implementation of a national registry, specifically dedicated to tracking surgeries for urinary incontinence and pelvic organ prolapse.
What kind of granular data is this registry actually capturing to prevent these blind laser injuries?
By law, this registry is required to capture an incredible depth of data. It tracks your NHS number, the specific hospital where the intervention occurred, the exact date of the procedure, and highly specific implant metrics.
Like what kind of metrics?
The exact material of the mesh, the manufacturer, the product's unique identification code, and the specific type of sutures utilized. It creates an indelible, legally mandated blueprint attached to your health identity.
And if late-stage complications do arise from an old surgery, a local general practitioner or a standard gynecologist isn't equipped to untangle integrated polypropylene from a bladder wall.
They absolutely are not, which is why the guidelines dictate mandatory referral to specialized NHS England complex mesh centers. These centers operate on a fundamentally different model, relying on regional multidisciplinary teams, or MDTs.
Okay, MDTs.
Yeah.
Yeah.
You aren't just seeing one surgeon who might have a blind spot. Your clinical presentation is evaluated by a syndicate of experts.
Wow. We're talking about urogynecologists for the pelvic floor mechanics, urologists to protect the bladder and ureters, specialist nurses, pelvic floor physiotherapists to manage muscle spasms, radiologists who specialize in reading complex pelvic imaging, colorectal surgeons for bowel tethering, and pain management specialists for trapped nerves.
Exactly. Because the mesh integration and the subsequent complications span multiple interconnected bodily systems, you need a dedicated expert for each localized environment to safely orchestrate an intervention.
It takes a village.
It really does. And this raises an important question for the broader medical community regarding long-term surveillance. The guidelines emphatically stress the necessity of tracking patient outcomes at least 5 years post-surgery.
If these things don't happen overnight.
Right. The architectural changes and chronic inflammatory responses caused by synthetic implants or complex scarring do not mature in 6 months. The true mechanical impact of a surgery often only reveals itself a decade down the line.
So let's pull all these clinical threads together. We started with the physical folder you carry, understanding that your cervical screening history, your obstetric injuries, and your old surgical notes aren't just administrative checkboxes designed to slow you down. They establish your body's vital cellular and structural baseline.
Exactly.
We examined how different surgical threads, like fast-absorbing polygalactin versus long-lasting PDS, dictate long-term tissue architecture and scar density.
We analyze the profound, permanent biological integration of vaginal mesh, exploring how the body's inflammatory response locks the plastic into the pelvic landscape, fundamentally altering how your anatomy functions.
And we broke down the distinct physics of modern gynecological lasers, from shallow water vaporizing CO2 lasers to deep penetrating ENDA-YAG beams. We proved exactly why a doctor requires your surgical history as precise targeting software to prevent catastrophic thermal injury to hidden plastics and altered blood vessels.
Your medical records are the ultimate safety mechanism. They are the only thing ensuring your physician isn't firing heavy medical artillery into the dark.
So what does this all mean? It means your documented past is the single most important tool for safeguarding your clinical future. But there's one final, staggering piece of this puzzle that the clinical guidelines left us grappling with.
Yeah, when reviewing the research recommendations embedded within the NICE guidelines, there is a glaring technological vulnerability the medical field is actively trying to solve.
Which is,
Currently, clinicians are still struggling to determine if standard ultrasound imaging is actually effective at visualizing where these older mid-urethral tapes and meshes physically sit inside the body.
you can't see them.
Non-invasive imaging simply struggles to differentiate the synthetic plastic mesh from the dense human scar tissue that has tightly woven itself through the pores. On a screen, the human biology and the synthetic material often blend into a single, indistinguishable mass.
Think about the gravity of that for a second. If our bodies are increasingly becoming these intricate, permanent hybrids of natural human tissue and synthetic industrial materials, and our most advanced doctors still struggle to simply see those implants without cutting us open, how drastically will the next generation of medical technology have to evolve just to safely map the physical histories we carry inside us?